Since we are with Dr. Michael Russo, neurologist, and Dr. Robert Child, anesthesiologist, we will pursue this conversation on the subject of pain. And I guess you have 2 points of view on the subject. First, how do you approach pain from an anesthesiologist, and what is your, holistic point of view on this subject?
Well, to understand and manage pain, we have to look at the physical anatomy and physiology, and we know that a electrical signal is generated by a pain fiber, a nerve fiber, somewhere in the periphery of your body, and it sends an electrical signal through a long passageway of nerve fibers up into your brain. But the actual experience of pain that you can consciously describe as pain is something that appears to be created by all these processing circuits, myriads of circuits that spread out to different areas of the brain. And is it something that is a part of, does the pain actually exist? If we recognize that maybe only 1% of what you actually are aware of consciously, 99% is processing that is occurring unconsciously in your brain. So where is this pain? Is it unconscious, subconscious? Is it only conscious? And how do we approach managing pain? Do we approach it by the processing in the brain areas, in addition to stopping that electrical nerve fiber conduction? How is the pain perception in the brain dealt with?
Well, generally it's through the thalamus and through the thalamical cortical pathways. So the thalamus will receive the signals from the nerves and then generate a type of pain, a severity of pain, a location of the pain once it communicates with the cortex. But some pain is worthless. Some pain is beneficial. If something hits your foot, the signal allows you to pull your foot away. That pain served a purpose. It told your brain to get your foot out of danger. But there are some pain signals that can be generated strictly by the brain that serve no useful purpose. And those pain signals, I think, are most amenable to your ability to concentrate, focus, meditate them away so that you could turn off unnecessary pain signals consciously. And that would be a wonderful thing to teach the students to do.
Is that in reference to what is described as chronic pain, which is pain that is persisting after whatever injury to the body that originally caused the pain? The original injury is healed up, but the patient still feels that there's pain there.
Yes.
Chronic pain, is that
like a circus current that repeatedly travels through the same regions of the brain, recreating the pain signal? Think of phantom limb phenomena, where if you have an amputation, the brain still feels pain in the hand, in the arm, that's gone, because the portion of the brain that controls the hand and the arm is still there, and it doesn't realize that there is no arm. So it generates the signals through the thalamus until there is cortical suppression. So the brain will eventually turn off useless pain. And in chronic pain, the phenomena does not work to suppress or turn off. It just continues and continues, despite the use of medications. Like patients on methadone or opioids They come in and they're still in pain, despite huge amounts of medications. So there have to be other techniques to get rid of that type of pain. Apart
Yeah,
from
if we look in the realm of holistic medicine, because the problem of pain, chronic pain today is tremendous. You know, the opioid crisis is one of them. So it's like, you know, what you do with this client, you know, how you manage, what is the holistic approach you offer to them to have an alternative to the medication.
Right.
So I think there is quite a challenge there.
And it takes courage.
Courage, but I said I can see a holistic approach there because we have many ways to deal with pain, from acupuncture, from laser, from microcurrent, and all these alternatives are not used actually in the healthcare or little. And then on the counterpart, many times these people has an addictive problem because they have been on opioid for a while. So this is where meditation fit in. It's like, you know, you have to feed this kind of addiction by something else. Right. And there's other studies, I believe, done with meditation where the threshold of pain is not the same. From long-term meditator, you know, they will feel the pain differently. The threshold of pain is very important. So studies with alcoholism, you know, we found that they have a very low threshold of pain, and this is why most of the time they go toward alcohol, because they can numb themselves, or they go in drugs, or they go other path. So the holistic approach, we kind of and let me, I'm addressing this question to you, you know, will be like a kind of a replacement, because it's like now there is a vacuum there. It's like everybody know that, you know, what we do with these people. You know, Canada, I know that in Colombie-Britannique they have clinic where they give opioid to people. They give the needles because they want to avoid the withdrawal symptoms. But this is certainly not the way to address holistically the problem. So what is your take on that?
Well, the most glaring concept that is not addressed specifically is that current anesthesia and pain research demonstrates definitively that treatment with opioids actually increases the perception of pain. Patients that receive opioid narcotic medications after surgery have more pain if you quantitate it using studies and follow-up, because of the effect of blocking these different receptors in the body. It appears that the brain, the body generate more pain receptors because we've given a drug, an external substance, to block one of the body's receptors. So the body says, hey, I don't have enough receptors, something's blocking them, I need to make more. With our most modern super synthetic opioid drugs, I can induce a withdrawal reaction similar to a heroin withdrawal in a user after months. I can induce it within 1 hour because the receptors are bound so tightly by these synthetic opiates, this fentanyl group of drugs, that there's certain fentanyls that will create this exaggerated response of need. So the perception of pain is a very important thing to be able to modulate. And if the neurological research suggests that biofeedback, neurofeedback, guided imagery, meditative states decrease the threshold of pain perception, then that may be, considering all of the current scientific evidence, that may be a bigger return on investment for decreasing the need for opioids. There's a lot of countries, and even in this country, 30 years ago, we didn't prescribe opioids for people. If a kid came in, with a broken ankle or sprained ankle or shoulder, you didn't give them narcotics. Everything is changed, so we probably don't need narcotics. We need another way of dealing with pain, and if a way of dealing with it from a mental point of view of modulating the sensitivity of your receptors may make more sense. Does that sound reasonable to you, or is that too far-fetched?
If you could downregulate the receptors, you'll feel less pain.
Yes.
So that's a wonderful approach if it can be figured out how to do that, because certainly blocking the receptors upregulates them.
Yes.
Yes, as you're pointing out.
So taking painkillers is going to give you more pain.
Right.
Downregulating, and probably the easiest, simplest way to regulate the receptors is to relax in some way. Is that correct?
And not use the opioids.
Yes.
So what is the portrait if you look at the brain scan? Someone in pain. So do you have like a signature, when you're looking at the brain scan, the pain?
When I'm looking at scans of patients, they're not particularly in pain. I'm not doing the studies for patients on pain. So I'm not sure what it would look like if the patient were sitting there in a great deal of pain. Usually they're relaxed, eyes closed, meditating, some of them, and they're very calm and comfortable. And that's the brain state that I aim for an individual when I'm doing the scans, because I'm looking for paroxysmal abnormalities that just jump out of nowhere, or slowing of the brain. If you have somebody who's had a stroke or is demented, various areas of the brain will be slower than other areas. So I'm not specifically sure what I would see if the patient were there and my arm hurts. I don't know quite what I would see in their brain scan on that, at least not with the EEG.
So, Dr. Child, do you see in hospital now a team where people can teach your client, meditation or some kind of biofeedback, or breathing is also very efficient, to heart variability, to prepare the client for anesthesia, or to manage the pain situation afterwards. So are you able to see this kind of intervention, or?
I see it in the future, in my mind's eye, in a perfect world, but as been alluded to in our discussions earlier, if a third-party payer, an insurance company, is not going to pay for something, it probably won't get done. The only reason that this was done in the cardiac surgery study case was because we could demonstrate that the hospitals were going to save money. For every heart surgery patient that is on a government assistant health insurance payment program like Medicare or Medicaid, the hospital was going to make an additional profit of 5% or 10% on that patient. So if there's a economic, energetic, environmental impetus to do that, and I think, as we know now, the most correct concept of medicine is what is referred to in essence as an integrative concept, which includes the biological state of being sick, the psychological state, the sociological state of how the organism is affected by the social group and the society and the communities in, and also the behavioral state, how the illness has changed his behavior. So it's not just the clinical medicine that we learned, 40 years ago, biochemistry, anatomy, physiology, and pathology. It's also the psychology now, which my parents, who were family practice physicians and went to see the patient at home and made house calls, that psychological component was a significant part of their decision on how to manage the patient. So that is coming back now. And the additional knowledge that the social matrix, the environmental, social environment we live in and interactions seems to be a key to health and recovery. Inflammatory markers are lower in patients that have good social networks.
So this is an important point we were discussing previously.
Right.
The inflammation marker, with the social level. And
right.
can you comment a little bit more about this?
Well, it is quite interesting that current research has shown that not only in illness do we see the levels of these inflammatory substances going up in the blood, heart disease, kidney disease, diabetes, hypertension, all these things we see inflammatory mediators going up. But we also see inflammatory mediators going up in people that are under stress. If it's a social situation, divorce, family crisis, we even see it in children. If you look at inflammatory mediators, we see that in early adolescence. We start to see a spike. We know that's the time when children going through all these hormonal changes in puberty and rapid growth of their brain and their mental perceptions, there's a sense of isolation because I'm different. It was like a girl going through puberty. I'm something's different. They feel a little bit disconnected. And then after the person gets into their 20s, the inflammatory mediators go down again because they're back, they know who they are. I'm a man, I'm a woman, and then you don't see inflammatory mediators go back up, until a crisis hits. So we know that the social situation can stimulate an increase in inflammatory mediators. And that same part of the brain that lights up in anesthesia research on a functional MRI that shows pain perception processed in the ventral, medial, frontal lobe. When the patient is experiencing a social rejection, we see that very same area. I'm not saying that's the center of the pain, but that's maybe the area where processing is communicated. And if we know that social rejection also causes inflammatory mediators to go up, that this inclusion in this integrative approach, you might even call it holistic approach, that we have to include the psychological and the social components in addition to the biological. And the most recent data that we know, and Dr. Russo may actually have a more detailed perception of it, is that the behavioral component, your behavior, how you react to your circumstance, is going to create more problems or less problems if you're making good decisions or bad decisions. If I'm sick, I'm not able to get out of the house, I've got a sore knee, I'm going to sit at home and eat the wrong type of foods that are going to increase the inflammation in my body. Or I'm not going to exercise because I'm going to have more pain when I should be out exercising. And behavior, when you isolate, when you disconnect from other people socially, we know that increases your inflammatory mediators. So if I can get you to behave in a way, I come over to your house and I say, hey, let's go out and go visit some people. Let's go to the park, let's do some community service. Let's talk about doing something for somebody else, making that social connection of commitment to somebody else. You see inflammatory mediators go down, but does the behavioral aspect of the functioning of the brain and the pain system and all these other components, does behavior seem to be a part of what you would say? It's almost like if your muscles are tense, you're going to have a headache. If you have a headache, it's going to make your muscles tense. So it's a two-way street in the brain. If you behave the right way, you're going to feel better. You know, if you're going to feel
When
better,
you feel better, you behave the right way.
You make the right decision.
Me, I like to come from the angle of consciousness all the time, because it's like when I'm hearing you when you speak, it's like this common denominator, inflammation, which is one of the pillars of health. You know, when you look at these pillars of health, one of them is what we relate to oxidation and inflammation. And so no matter what, it may come from a stress behavior. As you said, you just spoke about these different, the biology and the physiology and the psychology and so on. But, you know, underlying everything is in meditation what we call entropy. You know, more you have entropy in the system, of course, higher is the inflammation and higher is the oxidation. So anything that can bring back the metabolism and the system to a point, you know, of rest, or where you have the less inflammation possible, anything that will work on this, you know, will achieve a better threshold of pain, or I don't know if I can say that, but, you know, bring back all the parameters in the other sense. And meditation is one of them. And today there's other approach. The microcurrent is one of them. PMF is also doing this. Antioxidants, proper nutrition, and of course behaviors. So if you have social interaction that are very anthropic, you know, the anarchic or disorganized, you know, of course you can create. But for me, it's like the bottom line is to create a metabolic or psychological, emotional, spiritual state where you are more at rest possible, more integrate possible. I don't know, it makes sense in your, and coming from the angle of consciousness in some way, you know. Because where is pain? When you look at it, but when you look at it from consciousness, this is where you come back to the model of Dr. Goswami. You know, the mind is what gives meaning to the experience, but how to understand that, you know, where it's located. You know, it's like, well,
the experience
an entanglement. So it's like, underlying everything, you have a set of possibility then that, can be manifested as the brain and the mind, give a meaning to what's going on. It's like you can be a deep state of meditation, and here you have this, excitation that you should be in the deep pain, but it's not the choice you do, because you are, where you are in a state of being that is beyond that. Or, I don't know if it makes sense to your model, but it's like when we come back to meditation, it's like the one that can, in some way, overlap all the aspect of this pie, this multiple. So, what do you think?
I think the mind is very powerful and can overcome pain with a positive attitude. So if you direct yourself to a pain-free place and you direct yourself to a healthy existence, you can achieve it. So if it's not life-threatening pain, where your finger is being cut off or your toes being cut off, then the pain, you can put it away with conscious effort. So I believe in that.
And this is where we try to train our students with these different kind of modality, from meditation to biofeedback, neurofeedback, breathing, heart rate variability also is a
positive affirmation.
Is a modality that is probably part of any protocol of pain today. So it's like, if you can train your client to this instead, when the pain arrives, you already prepared your client to be, to raise the threshold of pain, to learn how to breathe, to learn how to meditate, sleep properly, and so on. Maybe that's the way to convince health insurance that at the end of the day, everything would cost less.
Well, I think where you're going is maybe what Dr. Russo can comment on is the use of biofeedback or neurofeedback to decrease pain, or meditation. Do you have any comment about biofeedback, neurofeedback in terms of reducing pain?
Well, clearly neuroplasticity is a very important component, and the neurofeedback allows neuroplasticity to occur. So if you're in pain and you're able to meditate and aim your neurofeedback at pain reduction, you're likely to be somewhat successful. So,
are there devices or techniques? Is there an app? Or how do I log on to something that will allow me to learn and utilize neurofeedback? Where do I go to get some of that stuff?
you go to Dr. Paul.
So this is, what we do is we familiarize our student with this smartphone digital technology. You can today download apps that works with a headband set, the Muse that can monitor your meditation. Your practitioner could be connected online, and know exactly, how your meditation is the meditation is productive. And there's so many meditation out there, from mindfulness and breathing meditation and mantra, and of course during the course we try to combine all these techniques together. And so this is why we familiarize our student to this technology, from meditation to heart breathing, the heart variability, and using device that help the client to build their confidence. Because when you have a feedback, this is where you get more motivated. You know that your meditation is efficient. You know that your breathing is optimal. You know that you're building this state of optimal health. And studies are there to show that if you practice heart variability, you have an optimal breath rhythm. At the end of the day, you have less cardiovascular disease. You have less, the better cortisol, better response to stress. So many studies that prove that you have better results. Meditation, the same thing. It's probably the placebo, the less expensive on earth, because it covers everything. From longevity, less cancer, less cardiovascular disease, better sleep too. You have 100 benefits associated with long-term meditation. So why not train people the same way we make them aware now that doing exercise is good, or having a proper nutrition is good, and why we don't teach them how to breathe, how to meditate. It's kind of another aspect of this strategy for health. So this is what we teach to our students. So I'd like to finish on this note, and thank you very much for both of you for your expertise. And I think it's very encouraging, because you coming from the anesthesiology, from so many years of practice and thousands of clients, and you as a neurologist, and both of you confirm that integrative medicine in some ways is the way to go for the next decade. Thank you so much.
Thank you for inviting us.
Thank you.
Visit quantumuniversity.com for more information.